Here's a number that should stop you scrolling. In the average GLP-1 trial, up to 30 to 40% of the weight people lose isn't fat, it's muscle. And in 2026, with tirzepatide pushing average weight loss past 20% and retatrutide knocking on the door of 30%, the question isn't whether these drugs work anymore. The question is, what kind of body are you going to have when you get to the finish line? Because losing 20% of your body weight while shedding muscle is a completely different outcome from losing 20% while keeping it. One leaves you smaller and stronger. The other leaves you smaller, weaker, and primed to gain it all back the moment you stop the medication. Today we're walking through the 2026 evidence-based stack, the 4 pillars researchers and obesity clinicians are converging on to help you keep the muscle while the fat comes off. Quick orientation before we dig in. GLP-1 receptor agonists semaglutide branded as Wegovy and Ozempic, and tirzepatide branded as Mounjaro and Zepbound have rewritten what's possible in weight loss. SURMOUNT-5, published in the New England Journal of Medicine in 2025, showed tirzepatide producing an average weight loss of 20.2% over 72 weeks, compared to 13.7% for semaglutide. Retatrutide, still investigational, hit 28.7% in its Phase 3 TRIUMPH-4 trial. These are bariatric surgery-level numbers from a weekly injection. But here's what the headlines don't say. When researchers used DEXA scans, the gold standard for measuring fat versus lean tissue, they found that across 7 placebo-controlled trials, roughly 30% of the total weight lost was lean body mass. That includes muscle. One 2023 obesity study put the figure as high as 39% on semaglutide. And before you assume tirzepatide is automatically better, a 2026 medRxiv analysis showed tirzepatide users actually lost more relative lean mass than semaglutide users, in excess of 1 to 2% more, depending on how long they were on it. So the goal of this video isn't to talk you into or out of these drugs. It's to walk you through what the current research says about preserving muscle while you use them. Quick note before we go further, these are prescription medications with real contraindications and side effects. Nothing here replaces a conversation with your prescriber and ideally a registered dietitian. If you have a history of pancreatitis, medullary thyroid cancer, gastroparesis, or an eating disorder, this is a conversation that has to happen with your doctor first. Let's clear up the biggest misconception first. GLP-1 drugs do not burn muscle directly. They don't have some hidden catabolic mechanism reaching into your biceps. What they do is suppress appetite so powerfully that most people end up in a steep calorie deficit, often without trying. And when you're in a deep deficit without enough protein and without a stimulus telling your body it still needs muscle, your body does what bodies have always done in a famine. It sheds the metabolically expensive tissue first. That's muscle. This matters because it means the problem is downstream of the drug, which means it's modifiable. The behaviors you stack on top of the medication are what determine your body composition outcome. There's a clinical concept emerging called the depletive metabotype, patients who lose more than 20% of their body weight, but also more than 5% of their lean body mass. That medRxiv study found this pattern in 10.3% of tirzepatide users and 6.7% of semaglutide users. These are people who got the weight loss they wanted, but paid an unusually steep muscle tax to get it. And here's why the muscle tax matters long-term. Every kilogram of muscle you lose drops your resting metabolic rate by about 13 calories per day. That sounds small, but it compounds. And when people discontinue these medications, which most studies show leads to substantial weight regain, the regain is overwhelmingly fat, not muscle. So you can end up at the same weight you started, with a worse body composition than you began with. That's the worst-case scenario these 4 pillars are designed to prevent. Pillar 1 is protein, and this is where most people on GLP-1s quietly fail. The current research consensus for GLP-1 users is 1.2 to 2 grams of protein per kilogram of body weight per day. For a 90-kilogram person, that's roughly 110 to 180 grams. But the total is only half the story. The other half is distribution. Muscle protein synthesis, the process that actually builds and preserves muscle, only switches on when you hit what's called the leucine threshold at a single meal. Leucine is the amino acid that triggers the signal. For most adults, you need about 2.5 to 3 grams of leucine in one sitting to flip that switch, which translates to roughly 25 to 35 grams of high-quality protein. For adults over 65, the threshold rises to 3 to 5 grams of leucine because of something called anabolic resistance. Older muscle is harder to stimulate. Here's the practical problem on GLP-1s. Appetite suppression often pushes people to graze, a few bites here, a small snack there. You might hit your daily protein target on paper, but if you never cross the leucine threshold at any single meal, muscle protein synthesis essentially never activates. The fix is front-loading. Get 30 to 40 grams of protein at breakfast when your appetite is highest, hit the threshold again at lunch and dinner, and consider a fourth feeding if your prescriber and dietitian agree. And here's a practical truth on these medications: real food often isn't enough. Liquid protein, whey shakes, Greek yogurt smoothies, even bone broth on nausea days, these aren't shortcuts. They're often the only way to hit the target. Pillar 2 is resistance training, and the data here is the most encouraging part of this entire conversation. A prospective study of 200 adults on GLP-1s who were also prescribed resistance training and protein education saw an average weight loss of 13%, with only about 3% muscle mass loss. That's a dramatic improvement over the 30 to 40% figures you see in drug-only trials. Translated, that means the people who lifted kept the vast majority of their muscle. The dose response is pretty clear: 2 to 4 sessions per week of resistance training, focused on compound movements, squats, hip hinges like deadlifts or Romanian deadlifts, pushes like push-ups or presses, and pulls like rows or pull-downs, with progressive overload over time. Progressive overload just means slowly making it harder: more weight, more reps, better form. And no, you don't have to look like a powerlifter or join a fancy gym. Bodyweight beats nothing, bands beat bodyweight, dumbbells beat bands, move up the ladder when you can. There's also a bone density angle here. Trials consistently show small but measurable drops in bone mineral density on GLP-1 monotherapy. A liraglutide plus exercise trial showed that combined therapy preserved hip and lumbar bone density compared to drug alone. So lifting isn't just about muscle, it's loading your skeleton in a way that protects bone, which matters especially for postmenopausal women who are already on a bone loss curve. Pillar 3 is going to feel counterintuitive in a culture obsessed with fast results. Slow down your titration. The faster you lose weight, the worse your body composition outcomes tend to be. The sweet spot in the current literature is roughly 0.5 to 1% body weight loss per week. Anything faster, and these drugs absolutely can drive faster, tilts the ratio toward more lean mass loss. That means working with your prescriber to use the lowest effective dose, climbing slowly through titration steps, and resisting the urge to chase the maximum dose just because you can tolerate it. There's also a growing off-label trend called microdosing, using subtherapeutic doses, like 0.05 to 0.25 milligrams of semaglutide, specifically for metabolic effects and muscle preservation rather than aggressive weight loss. I have to be straight with you here. Microdosing is currently unstudied in randomized trials. It's an interesting hypothesis being explored largely in compounded gray market settings, and the safety and consistency of those products vary widely. This is not a protocol I can recommend based on the evidence we have. If your prescriber raises it as an option, that's a conversation worth having, but it's not something to chase on your own. The broader principle still stands: gradual loss preserves muscle better than rapid loss. Plan for the long game. Pillar 4 is supplementation, and here's where I want to be careful. Supplements are the smallest lever of the four, not the biggest. Protein, lifting, and slower titration matter more, but within that context, a few have genuine evidence. Creatine monohydrate, 3 to 5 grams per day. It's the cheapest, most studied muscle supplement on Earth, and early observational data in semaglutide users showed better retention of lean mass and strength than non-users over 12 to 16 weeks. Take it daily, training day or not. And no, the small amount of intracellular water creatine pulls into muscle is not fat regain, it's a feature, not a bug. HMB, or beta-hydroxybeta-methylbutyrate, at 3 grams per day. HMB reduces muscle protein breakdown by about 20% in a caloric deficit and in dieting studies preserved 70 to 80% more lean mass than placebo over 8 weeks. It's especially worth considering during the most aggressive weight loss phase and for adults over 50. Vitamin D, calcium, and magnesium for bone density, particularly important for postmenopausal women. And hydration with electrolytes, because GLP-1s can blunt thirst cues and increase risk of nausea and dehydration. One caveat: if you have kidney disease, clear creatine and HMB with your clinician before starting. They're well tolerated in healthy adults, but kidneys are the exception. Before we wrap, you should know about what's coming. The most interesting drug in the muscle preservation conversation isn't a GLP-1 at all, it's bimagrumab. Bimagrumab blocks the activin type II receptor, which is the molecular brake on muscle growth. As monotherapy, it actually grew muscle by about 2.5% while shrinking fat. In a phase 2 trial combining bimagrumab with semaglutide, presented at ADA 2025, participants lost 16.4% of their body weight, and 92% of that loss was fat. Lean mass dropped only about 2.3%, compared to 7.4% in the semaglutide-only arm. That is a genuinely different outcome. Bimagrumab is still investigational and not FDA approved as of 2026. It's in combination trials with both semaglutide and tirzepatide. It's not something you can ask your doctor for today. But it tells us where the field is heading: combination therapy that decouples fat loss from muscle loss. For now, the 4-pillar stack: protein, lifting, slower titration, smart supplementation, is the best evidence approach we have. And honestly, it's the foundation any future drug combination will be built on top of, not a replacement for. Let's land this. If you're on a GLP-1 or considering one, here's the actionable summary. 1. Get a baseline DEXA scan if you can, and repeat it every 3 to 6 months. The scale lies about body composition. 2. Hit 1.2 to 2 grams of protein per kilogram daily, distributed so you cross the leucine threshold at 3 to 4 meals, roughly 30 grams of high-quality protein per sitting. 3. Lift 2 to 4 times a week, compound movements, progressive overload, non-negotiable. 4. Slow your titration with your prescriber's help. Aim for 0.5% to 1% body weight loss per week, not more. 5. Add creatine at 3 to 5 grams a day. Consider HMB at 3 grams a day in the aggressive phase. Cover vitamin D, calcium, magnesium, and hydration. 6. When you get to your goal, talk to your prescriber about a maintenance dose rather than stopping cold turkey, because rebound is mostly fat regain. The studies we walked through show this is achievable. People are hitting 13% loss with only 3% muscle loss when they do this right. That's the outcome to aim for: smaller, stronger, metabolically healthier, and durable. Work with a prescriber, work with a registered dietitian if you can, skip the gray market shortcuts. And if you found this useful, like and subscribe so the next deep dive shows up in your feed. Take care of yourselves.